Danielle, did you want to say anything first?
No, I'll leave it to you,
Okay, let's get
Mildred.
started then. Well, good morning, and thank you, Haruv, for hosting this event for us, and thank you in the audience for joining us. Today, we're going to have a little bit of conversation about infant crying patterns and how that can trigger abuse. As she said before, I'm Mildred Ramsey, and I'm a community nurse educator at the Parent-Child Center in Tulsa, Oklahoma. My co-presenter, as she said, is from the National Center on Shaken Baby Syndrome. Our objectives today and what we hope to impart to you. Got the objectives going, Danielle? Next. Okay, there we go. The thing that we're going to talk about today, and we'll give you information on crying patterns. We'll talk about how inconsolable crying can act as a trigger for child abuse. Danielle is going to share some information with you about a research-based program that has been developed to prevent injuries associated with abusive head trauma and shaken baby syndrome, which is one of the worst forms of child abuse that we know about. Today, we'll talk a little bit again about the stimulus. The next slide. We know that the infant cry is one of the most powerful things that a human can do. Our brains are wired to respond to that stimulus. What happens is that the baby cries, your brain is stimulated, and you decide as the caregiver or the parent whether or not you need to go provide some nourishment or do you need to go protect this infant from a predator. Again, infant crying is all about survival. It's survival of all generations. Cross-cultural studies have also shown this to be the same. However, even though our brains are wired to hear and respond to infant crying, for some people, when the crying becomes inconsolable or they deem it excessive, then they can really have some severe reactions such as increased stress. They can have frustration, and in some cases, it places the infant at risk for child abuse. We know that when we hear and read a lot of the stories of the perpetrators, they're usually saying things like, they didn't mean to hurt the baby, they just wanted the crying to stop. The one thing here that some researchers have said is that it causes our brain to react in a way like we do with flight or fight. And one of the things that causes us to become panic, we can't really start to control our thoughts. And again, we're trying to look for survival. We're trying to figure out a way to decrease the crying. The pandemic that we're going through right now is another reason that it can increase our frustration. We know that families are being asked to shelter in place, spend more time together. And what I'm hearing from a lot of new parents is they're not taking their babies out at all because they don't want them exposed to this COVID-19. So that means a lot of families are spending time together, babies are crying, and one of the things that they do, they're looking at the mother or the parents to be able to stop the baby from crying. They feel that's their primary duty. Can you just control that infant crying? The other thing that we found is that in situations of domestic violence, and in those cases where there's some substance abuse, these perpetrators or people in the family might be more prone to become more aggressive or very angry with the crying baby. Dr. Ronald Barr, who is at the National Center on Shaken Baby Syndrome, made this statement. And what he's saying is that in the early research years, what they did was look for ways that they could modify the risk for abuse. And their first thought was to look at to see what's going on with the infant. What can we do with the infant that will decrease the likelihood of this baby being abused? And now that they've done a lot of research, they've put out a lot of educational materials, and more people are in tune and understand that it is normal for babies to cry. In his most recent research, though, he says more accurately, it is not the crying itself, but the caregiver response to the crying that is a major and possible modifiable risk factor. So we know based on this that now we're going to focus on helping people understand how infant crying can trigger them to become frustrated, angry, and maybe even abuse the child. So this first little exercise that we're going to do, and I'm going to ask you to respond based on your experience. We know that our response to infant crying is truly based on our experience. it's based on our beliefs, and it's based on our perceptions. Let's look at the experience part. Use the chat box to respond to this question. When you were a child and you cried, what did people say to you? Some people are saying they heard it's okay. Some people heard stop crying. It's okay, you're tough. Exactly some of the things that I hear when I'm out doing the presentation in person. We hear an awful lot from people that said, they said, what's wrong? What are you crying for? Stop crying. And one of the things I've noticed that if we change the punctuation mark at the end of those sentences, we could hear like, stop crying. We could hear like, what's wrong? And one of the things that I hear more often is that somebody will say, stop crying, or I'll give you something to cry about. I'm sure many of you've heard that one as well. For me, I heard an awful lot about hush up that noise. If I heard hush up that noise, then one can imagine that 99% out of the time, if I hear crying or hear a baby cry, my first instinct is, oh, noise. And if we hear this as noise, then one of the things that we want to do is shut down the noise. That's just common. Now, my work with the Period of Purple Crying allows me an opportunity to develop a new understanding of infant crying, that is not noise, that it is normal for babies to cry. One of the things I know too is that our experience based on our childhood, from what we were told and how we respond to that, one thing I know is I probably heard hush up that noise. I translated that into something personal that would say, okay, it's okay for you to cry as long as you cry softly. And again, that impacts our response to infant crying. The other thing that we've heard about during our sessions with Haruv is the fact that trauma plays a big part in our past trauma plays a big part in how we react as adults right now. Our current experience or past experience with mental illness will also impact how we hear infant crying. And one of the things that the research is now showing, since we're working with infant crying during a period of time, the postpartum period, it can be almost clearly correlated to postpartum depression. It's happening during the same period of time. One of the things about parents that are experiencing depression, they may not be able to respond to the infant cue of crying, or they may, if they're anxious, they may be responding to it out of frustration and more stress. The one thing again is that COVID-19 has caused all of us to become a little more stressed because we're spending so much time inside and don't actually have access to social interaction. Okay, the next one. Let's talk a little bit about our beliefs. Here's another one to respond to in the chat. What constitutes crying for you? Is it tears, or is it the sound? Let's see what people are saying. Some people are saying both. Both, the sound. Well, what I'm hearing from when I do the presentations again, what I hear, it's okay, Danielle, to go to the next one. What I hear is that a lot of people are saying that they have to see tears. A lot of people say, well, if I see tears and I don't hear the sound, then I call it crocodile tears. If I hear the sound and I don't see any tears, then especially the teenagers that I work with, they call it fake crying. Newborns that our beliefs also may come from the fact that we might believe that newborns that cry a lot are spoiled. Or some of us believe as caretakers, we think, okay, I fed the baby, I've changed the diaper, I've done that little nurturing and cuddling, and the baby should be fine. Well, the truth of the matter is newborns can cry as much as 5 hours per day, and it will still be considered as normal. And did you know that tears may not appear in newborns until the baby's about 1 to 2 months of age? So if you're one of those people who have to see the tears, then you've missed an important part or some important cues that the baby might be giving in order for you to take care of it. The one thing it's really hard to get across to the teenagers is that infants cannot fake cry. A 6-week-old is not fake crying. They're not trying to get at you, and babies that young cannot be spoiled. Here's a little tear trivia for you. Did you know that humans had 3 types of tears? We have those basal tears that lubricate our eye. We have reflex tears, and those are the tears that if you go outside, something blows in your eye, you don't even have to think about it. Your eye just tears up, okay? And the third type of tears are those called emotional tears. And supposedly humans are the only ones that can shed emotional tears. Although some of the research I've shown say that perhaps elephants can shed emotional tears, and believe it or not, crocodiles do have tears, okay? Let's say you're one of those people who have to hear the sound. What are your beliefs about the sound? Some people believe about the sounds that crying, we hear grandma and big mama say, crying makes those lungs stronger. Let her cry. Let that baby cry. You hear an awful lot about, let that baby cry or you're going to spoil him. So those of us that have had the newborns, the baby's crying, you're caught up between what you know and believe, what you're hearing in the new literature, and you have your elders telling you something else. And so you're having to try to figure out, okay, what is it that I can really do with this infant crying? A lot of teenagers, again, give me the conversation about the fact that infants are just crying to get at you. And it's really difficult when I talk to them to get them away from that belief that the infant is really trying to get at them. The other thing that we've heard an awful lot about is the fact that the mother should be able to come and quiet the baby. Well, the truth of the matter is regarding sound, we know that all babies will experience a normal crying curve. That means that all babies go through it, regardless of being in the United States or other countries. All babies go through it. It starts when the baby's approximately 2 weeks of age, peaks when they're about 2 months of age, and will gradually go down. All babies go through it. It is true that all babies will have their own cry print. And the other thing is that's really true that we've heard a lot of mothers talk about is the fact that a mother can recognize her infant's cry print. And in fact, I've heard a lot of mothers who breastfeed, and they are out in public and they talk about the fact that they will hear a baby cry and their milk will let down. So again, our brains are primed for us to hear babies cry and respond. The other things about infant sounds of infant crying is that it's a really complex interaction to have to cry, to be able to make the sound, and to have the tears appear. And if you'll see here just by this slide, most newborns have a maximum voice point of 570 to 680. And look at the voice point for those babies that are born premature. Babies that are born with central nervous system disorders have an even higher voice point. And so what that does is that puts those babies at risk for shaken baby syndrome, because they are crying louder than the other newborns do, and it may be a trigger for anger and frustration. There's information too now that our hospitals are seeing more and more babies with what they call neonatal abstinence syndrome. And they are saying that these babies also cry with a higher voice point. The one thing that research has shown is that men and women's brains do hear crying differently. Maternal hearing, maternal caregiving, moms will usually hear the infant from the perspective like, what's wrong with the baby? How can I go help the baby? And it's all about caring for the baby. However, when men's brains are shown, they are usually responding from the point of, okay, what's wrong? How can I fix it? How can I fix it? And again, in defense of a lot of the perpetrators, because a lot of the men are the perpetrators. I think 70% of the perpetrators of shaken baby syndrome are men. So it is true that maybe the men hear the crying different. And I think Danielle will share with you too, is the fact that the victims of shaken baby syndrome are usually boys. And so maybe there is something to the fact that men hear the boys cry. They have this belief that boys shouldn't cry. So maybe they are responding differently to that cry. And the last bullet there is something that you can look up when we end our session today. I don't know if you've ever heard of this, is CRI du chat. And that is cry of the cat syndrome. And it's a genetic disorder, and it has a very distinct cry print that sounds just like a cat crying. So again, babies that are having central nervous system disorders, babies that are born premature, babies that are born having addicted to substances will have a different cry point and may cause us to respond differently to that cry. Now let's talk a little, we've talked about our experiences, we talked about our beliefs of crying, and now what we want to do is talk about our perceptions, because this is a big part of our response to infant crying. It's based on whether or not we know why the baby is crying. If we think we know why the baby is crying, then we will respond positively, don't have a problem. And once that happens, we're all feeling really good. The baby cries, we respond, the baby stops crying. And during that period of time too, there's a little bit of reward system that's going on. I got it. As a mom, I was able to take care of my baby's need. However, you're gonna go to the next slide, Danielle. Okay. When our perception and appraisal doesn't really match what's going on in our conclusion, like the baby cries, I feed the baby. Baby cries again and say, oh, okay, maybe the diaper needs to be changed. It cries again. Okay, you say, I'll hold and I'll do all the soothing techniques that I know to do. The baby is still crying. And this is when our perception of the crying can really, really get in the way of providing care for the infant and may lead us to child abuse. A lot of times the baby keeps crying. As a new parent, you're beginning to feel incompetent. I don't know what I'm doing. It's a bad baby. I'm a bad parent. I don't know what else to do. The stress starts to build. And for a lot of us, with that shared emotion that parents have and caregivers have with the baby, the more stressed the parent becomes, the more stressed the baby becomes. And pretty soon, it's just a vicious cycle. The thing that I want to leave you with before Danielle starts is kind of like thinking in terms of the fact, again, it's our response. We know that all babies are going to cry. They're going to go through a period when the crying is going to get longer and louder. So we as providers and people who work in the child abuse prevention arena, working with our families to help them understand it is our response. And we can modify our response. Just take a look at some of the comments that I found from some of the perpetrators. They said, I didn't mean to hurt the baby. I just wanted the baby to stop crying. Or the other one is, I didn't want to hit the baby, so they decided that shaking the baby was much better for the baby than hitting the baby. And the last one there is, I shook her so she would be quiet. I was exasperated. And at the end, the perpetrator is saying, I was crying just like she was. So again, the perpetrators don't set out to injure any baby. They're basically trying to get the baby to stop crying. And now we're going to hear from Danielle, who is going to talk to you about a research-based program that has been developed to help us prevent shaken baby syndrome. Danielle?
Yes, thank you for the opportunity. I am really excited to tell you about the Period-Appropriate Crying program. The following little segment is going to talk about the rationale of the program and the research behind the program and specific information if you're interested in delivering the messages to parents. Right now, I believe most of you are from Oklahoma. Is that accurate, Gal? Yes, so it is being implemented in majority of the hospitals throughout Oklahoma in partnership with the Oklahoma State Department of Health. In 2009, the American Academy of Pediatrics recommended that shaken baby syndrome be included in the broader concept of abusive head trauma. However, for most people, the term shaken baby syndrome is better known. For this presentation, I'll be using the term shaken baby syndrome. So what we're going to talk about today is how knowledge of the crying of normal newborn babies can be used to prevent shaken baby syndrome and the infant physical abuse generally. So we've talked already about how crying and colic is normal. And then now we're going to talk about how this is the most common stimulus for shaking. And then how shaking is very dangerous caregiving behavior. So what is shaken baby syndrome? So this animation will show you how the way the infant's head moves back and forth during a shaking event. You will notice that it's not just back and forth motion, the baby's head is moving in a figure 8 motion. It's the rapid acceleration and deceleration as the head moves back and forth that contributes to the brain injury. Factors that contribute to a baby's vulnerability include their weak neck muscles that offer very little resistance and their relatively large head size that can actually add to the momentum during the shaking. However, the most important factor is that the person doing the shaking is so much more violent. So much more violent act. And so, I'm sorry, my computer just went undone for a second. The person who's doing the shaking is so much more powerful and than the baby, and they're repeating the violent act over and over again. This animation gives you some idea of what's going on inside the baby's head during the shaking. As you can see, some of the parts of the brain move back and forth in opposite directions from other parts, resulting in shearing forces that damage the nerve cells in the brain. As the shaking continues, some of the branches of the veins coming from the brain begin to break, resulting in blood being released near the surface, producing a subdural hematoma, and sometimes a subarachnoid hematoma. This damage to the brain cells initiates a whole cascade of chemical reaction that increases the damage, producing, among other things, swelling of the brain called edema. It is often the swelling that results in the most serious of consequences. So this slide will actually illustrate the mechanical stressors caused by shaking that are produced in the eye, both inside the eye and around the optic nerve muscles. The back and forth motion results in some parts of the lining of the eye, referred to as the retina, to tear. This also produces different types of bleeding or hemorrhages, both in the back and the front of the eyes. One type of the hemorrhage is a sort of bleb that can fill up with blood. Unfortunately, the outcomes for infants who are taken to the hospitals are poor. In published studies, as many as 19 to 40% of babies die as a result of shaking. Of those who survive, 65 to 80% have significant long-term neurological and developmental disabilities and abnormalities. According to a study done in North Carolina, approximately 1,200 to 1,400 hospitalized cases of shaken baby syndrome, or about 30 per 100,000 children per year, are reported in the United States. A recent study examining cases through the National Kids Inpatient Database reported approximately 22 recognized cases per 100,000 children in the United States. The known incidence is likely just the tip of the iceberg. According to a study published by Dr. Carol Jenny, 30 to 40% of cases are missed at the medical institutions. So now let's look at how how crying is actually related to shaking, and how, because it's can be very frustrating to parents. I do want to mention real quickly before I move on that we are seeing an increase in abusive head trauma cases, as Mildred had mentioned previously. We know it's a difficult time to talk about prevention. However, because of the pandemics, we are seeing an increase. Early data and past studies show that in times of increasing social pressures and economic uncertainties, child abuse, especially abusive head trauma, increases. While AHT has always been a serious concern, we anticipate that will become a more frequent occurrence in the coming weeks and months as families are trying to navigate this new normal. That's why we really want to invite everyone to implement evidence-based prevention programming, and implement prevention fully, and to remind parents never to shake a baby. So as for the crying, in addition to the information that Mildred shared, talking about how crying is normal, but how it can be extremely frustrating, we wanted to talk about some studies that were done. So the hypothesis is that if crying is a significant stimulus for shaken baby syndrome, then the pattern for age-related incidence of shaken baby syndrome should be similar to the age-related properties of the crying curve that Mildred showed earlier. So to support evidence that crying and shaking are related, this direct information was available in the Shaken Baby Syndrome Victim Database kept by the National Center on Shaken Baby Syndrome. This database is made up of publicly reported SBS cases, and because they are mostly news stories, they often contain information about the stimulus to shaking. When Dr. Lee Barr and their colleagues graphed the 591 shaken baby cases by age, regardless of the specified trigger, see the blue line, you can see the shape of the curve is virtually identical to the curve obtained by that you have seen in crying curves previously. Then they looked at the 166 cases that were mentioned crying as a specific trigger for shaking. You saw that red line. It can be clearly seen that the curve has the exact same shape as the overall curve. And of course, as I mentioned, they are both similar to the crying curve. So now we turn to what we do about this. If our knowledge of the dangers of shaking and the normalcy of increased crying in early infancy come together, because crying is the most frequent and important stimulus for shaken baby syndrome, does this provide us with an opportunity for prevention? We think it does, and this is where the prevention program developed by the National Center on Shaken Baby Syndrome called the Periprobal Crying comes in. It takes all of this evidence and puts into a parent education package. It addresses the crying, shaking, and the timing of this normal development of crying in the lives of infants to prevent shaken baby syndrome from happening. The Periprobal Crying program has two aims. The first aim is to support caregivers in their understanding of early increased infant crying. The second aim is to reduce the incidence of shaken baby syndrome. The challenge has been to incorporate these important lines of evidence into a set of prevention materials, and this has resulted in the program called the Periprobal Crying. The reason it's called purple is that each letter stands for one of the 6 properties or features of crying in normal infants that contribute to the frustration and angers that caregivers experience. The first P stands for the peak of crying, where the amount of crying goes up and up, peaking around the 2nd month of life, and then begins to decline about 3 to 5 months of age. The U stands for unexpected, referring to the fact that these crying bouts begin or end completely unpredictably and for no apparent reason. They are not related to dirty diapers, feeding, or anything else that's going on in the baby's environment. R stands for resist soothing, when nothing a caregiver tries can calm the baby down. The second P stands for pain-like face, when the infant looks like it is in pain even when it's not. This adds to the anxiety and frustration of the caregiver. The L stands for the fact that these bouts are long-lasting, averaging about 35 minutes per bout during the first few weeks and months of life, though the crying could go as long as 5 hours as long as 5 hours or more. The E stands for the fact that the crying tends to cluster in the late afternoon and evening hours, often when the caregivers themselves are most tired and frustrated. The other important word in the name is period. This reminds caregivers that the crying does not go on forever, but only for a particular period in the infant's life. The take-home message for caregivers is to try and soothe the infant as much as possible, and when the crying is frustrating, to increase the carry, comfort, walk, and talk responses. This can decrease the amount of crying by up to 50%. However, if the crying gets too frustrating, it's okay to put the baby down in a safe place and take 10 to 15 minutes break to calm down. It is better than caregivers calm down first before trying to calm the baby. Never shake a baby or child. If there are concerns with the baby's crying, that they should be seen by a doctor or a health professional. We believe that these materials will help caregivers cope by providing new understanding that early infant crying, especially inconsolable crying, is normal, and there will be times when a caregiver will not be able to soothe the baby. It is also helpful to know that crying is not the fault of the caregiver or the baby, and the crying that will come to an end. So these are some of the protocols we've established for delivering the Periprobal Crying materials. So to ensure that all parents and temporary caregivers receive and understand the Periprobal Crying program messages, the program envisioned a 3-dose exposure. Some organizations, like the hospitals, similar to what we're doing in Oklahoma, may implement dose 1, but may not implement dose 2 or dose 3. This is okay. The program includes resources and tools for each of the 3 doses, whether your organization will do dose 1, dose 2, or all 3. Dose 1 describes delivery of the intervention materials to parents of all newly born infants with a demonstration of the materials by a trained educator or nurse. The timing of each dose delivery depends on the number of factors. The first dose of the program needs to take place within the first 2 weeks of a baby's life before the baby's crying increases. For example, the maternity delivery setting is ideal because it's universal, meaning most babies are delivered at hospitals. However, home visiting programs, pediatric, well baby visits, and public health, to name a few, have also been a good fit for dose 1. Dose 2 reinforces important messages of the program, such as babies can still be healthy and normal even if they cry up to 5 hours per day, and the crying will come to an end. However, it is also meant to catch any parents who might have missed dose 1 during maternity visit. Public and state Department of Health programs, home visiting, and pediatric well baby visits are some of the places where reinforcement of the messages to parents can take place. Dose 2 is a little bit more flexible in terms of timing than dose 1, generally occurring within the first 2 or 3 months following a baby's birth. The third dose is a public education campaign. Dose 3 is important to make sure that all members of a society hear about and understand the period of purple crying. The National Center on Shaken Baby Syndrome online training modules have a Dose 3 public education campaign toolkit with resources and downloadable assets for small or large campaigns, single events like a radio or TV advertisement, and case studies describing events and successful campaigns. Our most popular media generating campaign is Click for Babies. Click for Babies is an initiative where volunteer knitters, crocheters are invited to create purple colored hats to distribute to newborns in hospitals with the period of purple crying program. Interestingly, they did this very well a few years ago in Oklahoma and saw a huge surge of caps because it was picked up nationwide. So it was really kind of funny. The timing for dose 3 is dependent upon a jurisdiction's or an organization's capacity to educate the community where dose 1 and ideally dose 2 are occurring. It's not set to the timing of a baby's birth. So I also want to share with you some of our most recent and relevant peer-reviewed published research. The research article, A Lifetime Cost of Abusive Head Trauma, Ages 0 to 4, published in the Journal of Pediatrics in 2014, summarizes the cost of implementing shaken baby syndrome prevention programs like the period of purple crying, including the cost of the program, materials, shipping, staff time, and training is completely recouped if just 2% of SBS cases are prevented. Dr. Barr also demonstrated the program saved hospitals 18% in costs by reducing crying-related emergency room visits by 29%. In British Columbia, the period of purple crying program intervention was associated with a 35% reduction in AHT admissions for infants under 24 months old. This article and research has been published in the Journal of Child Abuse and Neglect and was recently selected as the Article of the Year for the journal in 2018. So providers have two options of the program materials, either the DVD booklet or the app and booklet. I'll be speaking about the app and booklet package, as that is the package that is most widely distributed in Oklahoma. The app booklet package contains the 10-page booklet and a parent reminder card. On the front of the booklet is a 7-digit activation code and QR code. When first activating the app, parents will be prompted to enter the activation code or scan the QR code. This only needs to be completed once. Other parents and caregivers will not have to enter the activation code or scan the QR code. The back of the booklet contains information of where to download the app and highlights a few of the cool features and helpful information available inside the app. The app can be shared on up to 5 devices per activation code, so this is very useful when we encourage families to share with anybody else caring for their baby. So it's important to, I do want to mention one more thing. We just recently updated the app and have included new useful features like a baby tracker, other health and safety tips. So it's really an encompassing app and a great incentive for parents to download and receive the information. The Period of Purple Crying program may have already been introduced to parents. Ask if the parents have received the Period of Purple Crying materials in either form. If the parents have not received the program, begin dose 1 delivery. If parents have received the program, begin dose 2 delivery. So a dose 1 delivery protocol. Let parents know that you're going to talk to them about is very important. It's called the period of purple crying, and it's a new way to understand their baby's crying. Provide parents with a set of the program materials. If delivering the app booklet, refer to parents to the front of the booklet for the app access code and ask him or her to access the program materials on one of their mobile or desktop devices. Use your own device if this isn't possible. When delivering the program materials to parents, review the booklet page by page and point out each of the important messages. The key messages include the purple acronym and what each letter represents, Early increased crying is normal and what to expect. Ways to comfort your crying baby, important action steps to take when the crying becomes frustrating. Sorry, it's not clicking, there it goes. Why it's okay to feel frustrated and what to do, why shaking a baby is dangerous and potentially consequences to, and be sure to tell others about purple crying and why sharing this information is important. Whenever possible, have the parents watch the 10-minute purple video. The teach back method involves asking your audience to repeat in their own words what they need to know or do in a non-shaming way. Teach back is not a test of your audience, but how well you explain a concept. It provides a chance to check for understanding and, if necessary, reteach the information. After reviewing the purple e-booklet, ask parents in a non-threatening way to describe their own words what they think are the important messages they learned. If parents are unable to recall a majority of the key messages, reteach the important purple message or rephrase the question. So let's switch to dose 2, which I feel is most of our audience here, and talk about the protocol for reinforcing the key messages of the program. First, check to see if the parents have been provided with the program materials. Second, recommend that the parents watch the purple crying video and go through the booklet again. Third, remind parents to share this information with other caregivers. And fourth, go through the dose 2 talking points or the booklet page by page to reinforce the important key messages of the period purple crying. So that is all I have and Mildred have. We want to thank you. She is going to kind of briefly talk about what we're doing in Oklahoma currently, but Gal has access to these slides, and this is our contact information for either myself or Mildred, and we're happy to answer any questions. But Mildred, do you want to go just quickly recap what we're doing in Oklahoma?
Okay, in Oklahoma, and specifically in Tulsa, we are implementing all 3 doses. As she said before, our first dose is implemented by nurses who make visits to all birthing hospitals in Tulsa, well, let's say pre-COVID-19. And now, after the information is introduced to them at the hospital, we have home visiting programs such as Nurse-Family Partnership. We have parents as teachers. We have a couple of Safe Care at our agency. And all of these home visiting programs work together to reinforce the message. We also have at the certain pediatrician's office, it's called Healthy Steps, and they again reinforce what the parents heard during the hospital. Right now, we're having more and more parents, they say, that might want to do birthing centers, and I was able to make a presentation to midwives and doulas regarding the period of purple crying as well. We also have child care providers who have access to this information through our Tulsa technology system. I provide training for our Head Start and Educator programs on an annual basis. We have a fatherhood coalition that has received training on the period of purple crying and have posted information on their Facebook page. And prior to COVID-19 and all the closures, one of the things that I was doing, because I noticed again that we said that most of the perpetrators are young men. So I have a relationship with some barbershops where I go around and they let me give information to all of their clients regarding the period of purple crying. So I have a baby that I can use and my gray hair and the purple jacket. So they just let me come in and sit down and talk to their customers as they are waiting for services. And we talk about the fact again that it is indeed normal for babies to cry. And I think one of the most important things, certainly again for us to remember today, it's normal for babies to cry. All babies are going to go through a period of time when the crying is going to get longer and louder than it was before. And during this period of time, you may not be, as a caregiver or as a parent, you may not be able to soothe the baby. And that's when you can become very, very frustrated. And the most important thing that we talked about, and Danielle talked about as well, is the fact that there's one proven way that we can prevent this is through education. And we tell the providers, parents, and especially young men, that it is okay to step away, calm yourself down, and go back and check on the baby, because it is not the crying. All babies are going to cry. It's our response to the crying that causes the injuries associated with abusive head trauma and shaken baby syndrome. Thank you. Questions?
Thank you very much, Mildred and Danielle. Thank you so much for this important, so important lecture. And we will give you all a few seconds. Mildred and Danielle, would you like to moderate the questions, or would you like Christina to do it?
I'm kind of keeping an eye on the chat box. So I think between me and Christina and Mildred, we can tackle it. Thank you, everyone, for your kind words. We're really excited for the opportunity to share this information. We're really proud of the program and the research that's gone behind the program. It's something that we're continuing to evaluate and model our program every time there's new research that comes out. And we want to make sure that it remains relevant to families forever. So there has been studies. There was a question if there's differences seen from parents with different cultures and how they respond. So there is a study from the Khoisan tribe where they respond very differently to crying than we do. The babies are held upright. They're constantly carried. They're breastfed almost every few minutes. Their crying is a lot less than what we see in Western cultures, but they do experience the same crying curves. So that was really interesting to know. There is not much done in Colorado at this time. They have the Children's Hospital in Colorado has a prevention program that they're doing. There are a few locations participating in the program, but not that I can think off the top of my head. We do have the peripubertal crying in about 2,000 locations right now through the world, mostly through North America and so Canada and the US. We do have a contract with the Department of Defense. So all families and all the branches of the military are receiving this information through their family advocacy programs, other new parent support programs. So we're really excited with that. Are there any studies for this in toddler age children and traumatic brain injuries from being shaken? So there are some studies done on the toddler age group. I can't think of anything off the top of my head. We do have on our National Center website, so don'tshake.org, we have a research library. So any research that has been done with the shaken baby syndrome, peer-reviewed research, published peer-reviewed research, we place on that website. So if you do ever have questions about any research, I encourage you to visit that website. Hopefully I'm not missing some. There's everybody's so great and great questions. I hope I'm not missing anything. So do we work with daycare providers and centers? So we do, and I'll let Mildred talk about Oklahoma. Do you want to mention what you do in Oklahoma? I can mention what we're doing statewide or nationwide.
Yes, we do work with daycare providers here in Tulsa. I have even gone to home care. And so the lady said, she didn't get credit for it. She said, can you just come when the babies are down for their nap? So I can be sure to deliver the program while the babies are down for their nap. Also through our Tulsa Technology Center, the class is free. And we do this about 4 times per year where we talk about infant crying and trigger for abuse and go over the period of purple crying with them. And as I said before, the what we call Head Start, Educator, Early Head Start, and I'm on their calendar to do an annual update always with them about the period of purple crying. But child care providers can access this information through the Tulsa Technology Center. I've taken it as far, I go to Owasso, and I've even done some training around Oklahoma City and even down in Atoka. So yes, I travel.
As the National Center, we offer a specific online training program for child care providers, specifically states. It's fairly new, but we're working with individual states to get it as an accredited program for their continuing education. So we're located in Utah, and we've done that, and we've had some grant funding to help us distribute it to all child care providers. And so it's at a really low cost. I think we charge $5 for access, and it's for one continuing education credit. And we talk about shaken baby syndrome, SIDS, other forms of abuse, and then we also incorporate crying, normal crying, and things like that. And so that's what we offer at the National Center for Daycare Providers. There's a question, does this program talk about sleep deprivation? So on our mobile app, for those who are doing the app and booklet package, we do talk about sleep and what it can do for parents, the lack of sleep, I should say. Additionally, we, as I mentioned, we are trying to always update it and keep it relevant. So we just received some grant funding, and we're hoping to get a little bit more to do another update next year, where we're going to address intimate partner violence, maternal depression, and parents of multiple children. So not like multiple births, but like if you have a 2-year-old and a 5-year-old and a 6-year-old, and how you handle those stressors. So that's going to be coming in the future. So these important topics, we want to make sure that we cover as much as possible in one kind of a one-stop, one-shot, I don't remember, you know what phrase I'm trying to say.
The one thing that I want to say, Danielle, too, is that for any of you in the audience that have had a baby that went through these periods of crying, and like I say, one thing for me is many, many years ago with the second child, I had no idea that anything about shaken baby syndrome. The baby cried. I tried to soothe the baby. The baby could not be soothed. She was 6 weeks old. Cry, cry, cry. And I did what most caregivers and parents will do, because you just assume there's something wrong with the baby. So I took the baby to the physician, to the pediatrician, and he's saying, back in the day, he said, there's nothing wrong with her. She's just spoiled. You just need to put her in the room, let her cry. So truly I did put her in the room, and she cried for a solid 2 hours. So there are those of us that have experienced that, and we know that the crying comes just about that time when moms are just really sleep deprived. Everybody in the family has tried to care for the baby, because we looked at the curve again. Starts when the baby is 2 weeks, peaks about 2 months, and then we'll gradually get better. Well, during that 2 weeks to 2 months, that's during the time when especially new moms have tried everything that they possibly can. They're tired, they need some help. And sometimes when it's the first baby, you know, most parents are don't feel like they want to ask for help. They just like, I'm competent. I can take care of my baby by myself. So again, sleep deprivation does an awful lot with it. I found an article the other day that also talked about infant crying and sleep later on. So there's lots of information that's out there about infant crying. And I would want to show you just the book that I have, if I can find it and show it to you. This seems to be the Bible on infant crying. It's 1985, but a lot of the more recent studies go back and refer to this book about infant crying. Lots in there about perception and about sound. So lots of information out there for you.
So there is a question about why do we require them to enter a QR code? So this way it's unique to that individual, and that the hospitals or the organizations that implemented the program are actually purchasing those packages from us. We only charge $2 per, which is very minimal, but that helps us do free nurses training, helps us do these webinars, helps us support the research, the program and things like that, and all the app updates, because apps are quite expensive. So we do charge that, but we're a nonprofit, so everything that we earn from that goes right back into supporting the program. Those QR codes are sold to the hospitals, and then hospitals can, or the other organizations can actually track activities within the app. So not individual, it doesn't give any personal information, but we can see like, oh, are they watching the book, watching the videos? Are they reading the booklets? What articles are they finding helpful? And then that helps us really see if there's a hospital not doing what they need to, they want to step up, or if we're seeing that something's being really effective, then it helps us address it that way. So that's why we do that QR code. So it says, does the program employ any mental health providers? So I'm not sure if you mean in Oklahoma or as the National Center. The National Center, we're only 9 employees, but we do have a social worker on staff that helps answer any questions that we have from families that come in. But it's not a hotline per se. For hotlines, we refer everyone to the Child Help Hotline. So another question, what are some common barriers you have experienced when providing the education? I would say time. that would probably be the biggest issue. We know that especially maternity nurses, they have a lot of information they're trying to give out to families between car seat safety and breastfeeding, shaken baby syndrome, everything else like that. That's probably the biggest issue that we see. That's why when we created the booklet and we continue to adapt it, we created a quick 3-minute script, and it just can go right by each page of the booklet. So it's something that's really easy for them to do. We've seen a lot of hospital systems incorporate it into their discharge portals. So parents are able to just watch the videos right through their hospital network. And that's really helped. Mildred, did you want to add anything?
The only thing I wanted to add in is, since I'm more in the community, I'm not in the hospital arena, I have heard our nurses, again, talk about what you talked about at the hospital. They provide information to anyone who is in that room at the time. Sometimes the dad is not as engaged as we think he should be, but we offer lots of opportunity to share more information. One thing that I found out in the community is, especially when I deliver the information to child care providers, it's really difficult to get people to step away from their beliefs about spoiling babies, and that you can spoil babies, and yes, and 6 weeks olds can be spoiled. And so it's really getting around those beliefs. It's really giving them new information, give them time to think about what we just said, and then probably it'd be nice to go back and repeat that. That's why it's worked so well for me to keep going back to Educator and CAP, because the first year it's like, okay, she's here, I guess we have to sit here through this. And then the second and third years, they ask more and more questions about infant crying. So again, challenges is time, because a lot of people want you to do it in 5 minutes. And as you can say, I'll talk forever, so it takes me more than 5 minutes, but time is an issue.
Thank you. I do want to just read quickly what Alicia Lincoln, in case you're not seeing the chat feed. So Alicia Lincoln is a representative at the Oklahoma State Health Department. She did want to let you know, if you're interested in obtaining a copy of the app to see if it's something appropriate for you or your clients as a dose 2 or the training, contact her at Alicia, that's ALICIAL, at health.ok.gov. They have 40 birthing hospitals in the state participating, but not all of them. So the more organizations we can have doing dose 2, the better, and the more saturated we can get the state of Oklahoma with the peripubertal crying, and hopefully really reduce those incidents of cases. So I had a question. So Mildred, what is the title of that book one more time that you liked?
The title of the book is Infant Crying, Theoretical and Research Perspectives, edited by Barry M. Lester, and the second editor's last name is Boukyddis, but I think if you put in Lester, that will help you get there. Infant Crying, Theoretical and Research Perspectives.
Thanks.
And since I am here in Tulsa, if there's an opportunity for me to present to anyone that you know or in your arena, just let me know.
Well, I'm going to. Thank you. Thank you, Danielle. It was nice to meet you.
You too. Thank you
so much
for having us. I really appreciate this opportunity.
Thank you, Danielle. We'll meet again.
Okay. Thank you, everyone.